So now we're going to talk about primary angle closure glaucoma. Okay, so as I told you that the basic problem is that the peripheral space between the iris and cornea is obliterated. Okay, obliterated or closed. So I told you there are two mechanisms, the two types. You have to do it with pupillary block. In the previous video also I've told you, and without pupillary block, right? Without pupillary block. Okay, so with pupillary block, I told you whenever there's pupillary block, what happens? Iris bombi will happen. Okay, and without pupillary block, you can say it as plateau iris. It is because of the anterior dislocation of the ciliary bodies, right? Okay, so that is the basic understanding. Now, what is the risk factors? Okay, and one more thing you have to remember, the maximum closure of angle will occur at mid-dilated pupil. So the maximum closure of angle occurs in mid-dilated pupil. In your mid-dilated pupil. Okay, so this much you have to understand. And now when I'm talking about the risk factors, so the risk factors will include your first, again here also there is family history, but there is no specific gene. Like how I told you in open angle glaucoma, there's myOC gene, optineurin gene, WDR35. All this in family, all this genetic, no specific gene is involved. And then if they have like a small eyes, if they have small eye, that's why maybe the anterior chamber depth is very less, and maybe it can get obliterated also very less. And then gender also predisposition is there, so mostly you can see it in your females. Okay, now what happens is that okay, so as I told you about plateau iris, you should know and all that. So in plateau iris, what is happening? One more risk factor is your plateau iris also. Plateau iris is also one of the risk factor. If they have these kind of iris, obviously this will be a problem because there's anti-rotation of the ciliary body, which will lead to your iridociliary contact. Okay, there's flat iris and chances of angle closure is there. Okay, now what is the mechanism? So mechanism, as I told you, mechanism, again the same mechanism you have to follow. So I told you again, you have to divide it into pupillary block. Okay, pupillary block and without your pupillary block. Okay, so with your pupillary block you have your iris bombi. Okay, without your pupillary block you'll have your plateau iris, right? This is something which you have to remember. Now, as I told you, investigations in this case, I will do my IOP with my tonometry. I will do my fundal changes with my slit lamp biomicroscopy. I will do my visual field effects with my perimetry, and along with that I'll do one more test which is called your gonioscopy, which is for your anterior chamber depth, to find my anterior chamber depth. Okay, so it is for your anterior chamber depth. For that I'm doing my gonioscopy. So gonioscopy does not need dilatation of the pupil, because I told you when the pupil is mid dilated, there is more chance of pupillary block. So obviously you will not want maximum closure will occur when there is mid dilated pupil. So obviously I would not do my gonioscopy when my pupils are dilated. Okay, now there are other methods also to find the anterior chamber depth. There are other methods, for first one being your gonioscopy, second one being your Van Herrick's method. So you have your Van Herrick's method also is there, and then you also have your third one, which is your Schaffer's grading system. Okay, all that is there. So we will talk about gonioscopy in detail. So in gonioscopy, what you will do is that, so gonioscopy, the examiner will visualize the anterior chamber. Okay, the angle of the anterior chamber from anterior to posterior. Okay, so to visualize the angle of anterior chamber, okay, from anterior to posterior. So you have to know what are the structures present, right? There is a mnemonic. It says that it is like can't see these stuffs. Okay, this is the mnemonic, but this is from posterior to anterior. Okay, so what is the C? You have your ciliary body, which is the most posterior. You have your scleral spur. You have your trabecular meshwork. And then you also have your Schwabe's line. So this is the most posterior and this is the most anterior. And this trabecular meshwork, you can have it divided. I told, like, there is one will be your non-pigmented, and this is your pigmented. Okay, so this is what, so can't see these stuffs. Okay, from posterior to anterior. Okay, so how will you say that, when will you say that the angle is occludable, like it is occluded? So occludable angle means that when the post-trabecular meshworks are not visible. So obviously you're going to see anteriorly, but post-trabecular meshwork, meaning this part. So post-trabecular meshwork, that is the ciliary body in the scleral spur, is not visible in more than 3 quadrants. So we'll define it. When post-trabecular structures are not visible. Okay, structures are not visible. Okay, not visible in more than 3 quadrants. Okay, so basically this angle is also called your ITC angle, which is your iridotrabecular contact. Okay, you get it? So now, okay, the principle. So how does gonioscopy act? So this is also in principle, because this gonioscopy is important. They can ask as short note also, in like gonioscopy itself they can ask as short note. Okay, gonioscopy itself they can ask as short note. So basically you have to understand a bit of physics is required. Now for example, this is my a dense medium. This is my dense medium. This is my air. So obviously we'll just put it as U1 and U2. So obviously U1 is more than U2, which is my refractive index of the denser medium will be more than the refractive index of my air. This is my normal. Okay, now whenever my incidence is falling, for example, this is my incidence. Okay, whenever, so from a denser medium, okay, denser medium to a lighter medium, if the ray of light is traveling, it will go away from the normal. Okay, this is my R. So whenever the light rays travels from a denser medium to a lighter medium, it will go away from the normal. Okay, so you have to know something about the critical angle. So critical angle means it is the angle of incidence. Okay, it is like, to critical angle, what happens is that it will be the angle of refraction will be coming like that. Okay, so what is the critical angle? Critical angle is defined as your angle of incidence, which leads to the refracted, so the angle of incidence which will lead the refracted light will be 90 degrees to the normal. Is that clear? So this is my angle of incidence. So I have to know my angle of incidence for my structures in the eye is to visualize it. Okay, so if you increase it more than, like if for example, if I'm increasing, so any increase in critical angle can lead to your total internal reflection. Okay, now see here. For example, now I am gonna a bit increase it like this. Okay, so the angle is increased. So maybe now what will happen is that there can be a internal reflection itself. Okay, so any increase from the angle of critical angle will lead to basically internal reflection. Okay, that is what you have to remember, right? Okay, so you have to remember certain points here, which is the refractive index of your aqueous humor is your 1.33, refractive index of your air is your 1, and then critical angle for cornea is your 46 degree. This is the some points which they have asked in exam, so you have to remember. Okay, so gonioscopy, you will not, there are two types of gonioscopy also. So gonioscopy, there are two types of gonioscopy lenses. There are two types. You have your direct gonioscopic lens and indirect gonioscopic lens. Okay, so yes, direct and indirect gonioscopic lens. So what are the indirect type of lenses? You have to remember there is Goldman, Zeiss, just remember the names, Sussman, all that. Here you have direct में, you have your Coipes, you have Swan, Jacob. Okay, yes, that is all you have to remember in gonioscopy. Okay, so what are the findings? Okay, that is about gonioscopy. Then you have something called a Schaffer system also I told. So we'll just see what is Schaffer system in brief. Schaffer system, it is one more way of finding the angle of anterior chamber. So you have to grade it. Okay, now you have the ACA grade, anterior chamber angle grade, and you have the angle status, and you have the visible structures. Okay, now we will go from 0, 1, 2, 3, 4. Okay, so if the grade is 0, angle is closed basically. So there is no visible structure at all. If the angle is 1, it is extremely narrow. Okay, it is extremely narrow. So what can you see? Schwabe's line, yes. You will only be able to see this Schwabe's line because you're seeing it from the anterior. No, though we have learned the mnemonics can't see these stuffs, it is from posterior to anterior, but you'll always remember when you're using a gonioscope, you'll always visualize the anterior structure first, then go into posterior structure. So when you're only able to see Schwabe's line, it is extremely narrow. And then what is 2? It will be narrow, obviously. And then what will you be able to see? You will be seeing till the trabecular meshwork. Okay, trabecular meshwork. Then when it is 3, it is open. Open meaning you will be able to see the scleral spur. The scleral spur is visible. Then it is wide open. You will be able to see the ciliary body also. Okay, so this is something which you have to know. Schaffer system you have to know. Then there was also, I told you, Van Herrick grading also I told you. Right, so Van Herrick is, again, it will be based on the corneal thickness. It depends, I mean, you have to compare the ratio of anterior chamber depth to the corneal thickness. Okay, so what happens, you have to write again that this is a tabular column only. Width of anterior chamber depth, you have your grade, and you have the angle status. Okay, so what will be the grade? 0, 1, 2, 3 and 4, right? Now, what is the angle status? Or I told you it will be closed. This again will be extremely narrow. This is same, okay, extremely narrow. And you will see this is the narrow, this is your open, and this is your wide open. But here as we were seeing the structure, the visible structure we were seeing, here we'll do width of the ACD. You're comparing it with the corneal thickness. Compared with your corneal thickness, right? So what is happening here? There is no blank space observed. So no blank space. Okay, here less than 1/4 of corneal thickness. 1/4 of corneal thickness. Here it will be your between your 1/4 to 1/2 of corneal thickness. Here will be more than 1 of corneal thickness. So you're just comparing with the corneal thickness, that's all. Okay, so that is what was the, how will you see the anterior chamber angle, okay, with the gonioscopy, Van Herrick and One more is your Schaffer system. Next. Now clinical features. Okay, clinical features of your primary angle closure glaucoma. Okay, so first you have to divide. Okay, so angle closure glaucoma patient, you have to divide into 4. Okay, so you have primary angle closure suspect, you have primary angle closure, you have acute primary angle closure, and then you have primary angle closure glaucoma. This is more like chronic. This will be more like chronic. Okay, now suspect. What am I saying when there is only a suspect of primary angle closure glaucoma? So first of all, the ITC angle is more than 3 quadrants. That point is there. You can see it in gonioscopy. But your IOP is normal. No peripheral anterior synechia. And eclipse sign is present. This is important. Okay. So eclipse sign is present. Okay. This is your primary angle closure suspect. What happens in primary angle closure? ITC angle is obliterated. Yes. Then IOP is raised, but pars can or cannot, may or may not be present. Okay, acute I'll also tell you, and then primary, this one angle closure glaucoma will be your, all the thing will be there, more than 3 quadrants. You will have IOP is raised. Okay, you have your PAS also is present, and then you have optic neuropathy. This is like proper glaucoma because optic neuropathy is also occurring. So suspect is that you have only this thing present, and there is eclipse sign also there. For primary angle closure, you have PAS may or may not be present. But what is acute? Acute primary angle closure glaucoma. Okay, so it is basically like acute, like sudden. It is like a suddenly the patient is having like symptoms of glaucoma. So what happens? Suddenly the anterior chamber, the anterior angle has been obliterated or closed, we will say, which is your grade 0. So that is completely it has closed, completely suddenly it has closed, and you will have again all this acute symptoms like redness you will have. Okay, photophobia you will have blepharospasm. Okay, blepharospasm. The IOP will be very high, like it will be like 60 mmHg it can go up to. You have pain, nausea, and vomiting also will be there. Okay, so examination, if I see your examination, the corneal, so in examination, what will I examine? There'll be corneal edema will be there. Okay, there'll be corneal edema. Okay, it is because of this, due to your IOP is like more than 60 mmHg, that's why there'll be corneal edema. Okay, and then colored halos will be present. Okay, then you have mid-dilated pupils. Dilated pupils will be present. Okay, all that. Alright, these are my examination finding. So why? Okay, now what will be my treatment? So all this, suddenly my patient is coming with like sudden loss of vision. Okay, suddenly the patient's vision is lost. There's a lot of pain. Okay, there's photophobia, there's floaters, there is corneal edema, there's all these symptoms. Okay, so what happens is that, how will I treat my patient? Okay, treatment will be so first, as I told you, what will you do? Because the IOP is increased, right? The IOP is very much increased. So I will give for my IV mannitol or IV acetazolamide. Okay, and then after your IOP has reduced, after IOP reduction, go for opening the angle. So how will you open the angle? Because it can be it can be completely closed. So you'll open the angle by pilocarpine. Okay, then what else is there? Corneal edema is also there, right? So corneal edema, how will you do? Corneal edema, how will you treat corneal edema? Yeah, you'll give 10% glycerin or hypertonic NaCl. Okay, now this is my treatment, but what will happen is that your definitive treatment should be your peripheral iridotomy. Peripheral iridotomy should be my definitive treatment also. Now, what will be my findings in a resolved and acute primary angle closure glaucoma? Primary angle closure. Okay, what will be my findings? So first, there's something called as Voigt's triad. Okay, so what will be my Voigt's triad is that you have your glaucoma fleccens. You have your iris atrophy. You also have your dispersion of pigments on cornea. Right. This is my Voigt's triad. Voigt's triad is there, but apart from that, you will also have your deciment membrane folds. Okay, you will have your cupping of the disc. Okay, you will have cupping of the disc can also be there. Okay, and then you also have cataract. Right. So what will you have after the AP that is APAC has resolved? You will have Voigt's triad, you have DM folds, you have cupping of disc, you have cataract. Okay, and the treatment will be my IOP will be increased, so I have to give mannitol and acetazolamide. After IOP, you have to close the angle. You give pilocarpine, and for corneal edema, you're giving 10% glycerin and hypertonic NaCl. Definite treatment will be peripheral iridotomy. So, talking about peripheral iridotomy, so what is peripheral iridotomy? Okay, what is my peripheral iridotomy? So I'll just write it over here itself. A more detail about peripheral iridotomy. So you're doing it with the help of laser, which is your ND YAG. Okay, that is the laser. And you will make an opening. Opening is made at around 11 o'clock to 1 o'clock position. Okay, and it is where is the opening made? Where is the opening made? It is made at the crypts. Made in the crypts, you will make an opening. Okay, and the lens which are using is basically your Abraham lens, which is your plus 66 diopter. Okay, that is about your peripheral iridotomy, which is the definitive treatment. But also one more thing, you have to, after this definitive treatment of peripheral iridotomy is done, you will do a prophylactic peripheral iridotomy in the unaffected eye as well. Okay, is that clear? Okay. Yeah. So now, as I told, this you understood, with the treatment you understood. But what is PSA? Suspect, will you do treatment or will you just leave it like that? Yes, you will do a prophylactic PI in both eyes, peripheral iridotomy. Okay, so you will do a prophylactic PI in bilateral eyes, you can just write. What about primary angle closure? So yes, again, you will give your prophylactic PI in bilateral eyes. APAC, you do. What about this one? You will give your anti-glaucoma drugs. Okay, anti-glaucoma drugs I will give, right? Okay. Right, okay. And then, okay, that's all. And yeah, this one, and then you also have to control the IOP, this also. Okay, so this and this. Okay, next you have to remember about your, okay. And this was about the clinical features. Okay, next I will be talking about your, that is all about this thing. Now, let us go to a topic called as secondary glaucoma. So secondary glaucoma can again be your open angle and your closed angle. Now it is because of some other disease which you are getting glaucoma, right? Closed angle. Now, what are the important diseases which you have to remember for secondary glaucoma is, you have to remember pigmentary glaucoma. Okay. You have your pseudo exfoliative glaucoma. You have your uveitis, lens induced glaucoma, malignant glaucoma, you have your neovascular glaucoma. So these are the things I will be discussing in detail, right? Okay. These are my secondary glaucoma. Okay, so in the next video, I'll be talking about secondary glaucoma. So yes, hope you've understood this one. Okay, hope you've understood this. In the next video, I'll be covering the secondary glaucoma. I'll be covering the treatment of all these glaucoma as well. Okay, thank you all.